Yes,
But
sir.
in our day, many times we get the with heart failure for any emergency operation. So if there is any emergency operation like laparotomy or other things we may have
Necessary,
from the
sir.
heart failure patient, in that of the antiarrhythmic, we simultaneously prepare the patient for the operation and at the same time we with heart stabilize the heart for with the any emergency operation. So now we have the emergency operation like laparotomy or other things we may have from the heart failure patient in that of the anti mellitus patient. Okay. So is implication of diabetes in case along dilated cardiomyopathy? What do you
Sir,
think?
sir, diabetes independent also poses cardiac risks. Sir, a diabetic patient, especially uncontrolled diabetic patient, will have a microvascular complication. They are at an increased risk of having perioperative stress hyperglycemia. The rate of exercise will increase and there is delayed wound healing. And so in the cardiovascular system, hypoglycemia causes endothelial dysfunction. This can lead to silent ischemia in patients. Autonomic neuropathy will blunt their tachycardic response to hydration. They are also at an increased risk for arrhythmias such as VT or ventricular fibrillation, heart block, especially if there is LVV, fibrosis, hypokinesia. And as DCM patients have all these, the risk is considerably elevated. Their diabetes independently can also cause certain structural damage such as VT, like or venous dysfunction, myocardial stiffness, even cardiomyopathy. And so a higher
Okay.
edge to preoperative MI, 30-day cardiac events, with the normal
Okay.
fasting or postprandial sugar, vascular have been established.
So long-standing diabetes, beside the microvascular complication for coronary artery, thing, there is a chance of dilated cardiomyopathy also. We have
Yes,
to
sir.
keep in this. There is separate diabetes in our case series, so we do not go details about diabetes in this. Concentrate on dilated cardiomyopathy and the lab. Now, my second question: what is the advantage of the lab over the open coli? Whether you advise the surgeon go for the lab coli or open?
So it is important. Laparoscopic approach to cholecystectomy has a smaller incision, which will cause lesser pain. So this will cause ultimately a lesser sympathetic stimulation. There is a and there will be reduced fluid shifts and third wave. Diaphragmatic splinting. From our point of view, there will be recruitment and enhanced recovery, but it is the surgeon performing the surgery must be.
Okay, then you prefer the laparoscopic surgery for this patient. But what are the danger of the laparoscopic surgery for this patient?
So laparoscopy surgeries in general cause certain amount of hemodynamic stress. So these are mainly due to pneumoperitoneum, also the positioning of the surgery. In this case, the patient is head up or a reverse Trendelenburg position. So the pneumoperitoneum causes an increased intra-abdominal pressure, and since CO2 is used as an agent, it can also cause a hypercarbia. So,
Okay,
so due to the
so
pneumoperitoneum,
okay, so the use is a pneumoperitoneum is a major concern for our anesthesists. Why? Why the pneumoperitoneum causes sympathetic stimulation?
sir, pneumoperitoneum will lead to an increased intra-abdominal pressure. So these will cause
Yes.
a pooling of the blood, increased venous resistance, which will cause a decreased venous return, eventually causing a decreased cardiac output. There is also some query as to if it's causing any inotropic effect. Our intra-abdominal
What?
increased intra-abdominal pressure will also cause an increased intrathoracic pressure. And all these will
Okay.
again increase the systemic vascular resistance, leading to a decreased cardiac output. In this patient, where the
All,
cardiac output is already, they may not be able to handle or endure this further decrease in cardiac output.
in case of laparoscopy, always we bother about the decrease in SBR, or anytime there is chance of increase in SBR also. What
Sir,
gas we commonly give?
sir, carbon dioxide.
The carbon. What if the operation is for a long duration? What?
Sir, there can be hypercarbia, which can lead to respiratory acidosis. Hypercarbia itself can precipitate arrhythmias, which is usually exacerbated due to the effect of
Yes.
respiratory acidosis. And so carbon dioxide itself causes some amount of sympathetic stimulation, which will cause cardia or cardiac depressant effect.
As insufflate the gas, there is the stretching of the peritoneum that caused vagal stimulation
Yes, sir.
of bradycardia. But when there is long-standing operation, peritoneum has a large surface, there is a that may cause the hypercarbia. Okay, this hypercarbia increase the sympathetic stimulation. To overcome the hypercarbia,
Sir, initially to make sure that the insufflation rate is not more than 1, we will make sure that the intra-abdominal pressures are at a maximum of the range of 10 to 12. So once they're making the ports, we'll allow it to 12. Once ports are settled and they're well comfortable in the abdomen, then we'll tell them to bring it down to 10. And sir, as clear strategies are concerned, we'll try to maintain a minute ventilation with an EtCO2 in the normal level. However, in this case, we have to note that we cannot increase the positive end expiratory pressure or PEEP too much, because again, that will hamper the cardiac output, which this patient will not be able to tolerate.
okay, very good. So not only the intra-abdominal pressure, the gas insufflation rate is also important. Okay, we cannot
Yes.
give the gas as a time. Okay. So what is the position of the patient in this patient? Patient is
Sir, in reverse Trendelenburg position or head up position.
so any analysis of this position, whether this position is suitable for us or any disadvantage for us.
The disadvantage here is there is a decrease in the venous return. Eventually, will lead to an load. And so this might not be well tolerated by these patients. A decreased preload may transfer this output.
And any advantage of this position? There
So,
is diaphragm should be there
diaphragm is good.
more diaphragm, so there is increase in the effort. Not get
Yes, sir.
in case of operation ovarian ovarian. Okay. Now I again Dr. Rajeshi for intraoperative period. Rajeshi.
Thank you, Shrikant. So, what will your anesthetic goal in this patient?
So, ma'am, my anesthetic goals to have a mnemonic will be fast, to keep the patient fast, dry, and dilated. That is my preload. I'll keep it at the normal levels, because the pump, because DCM is basically a pump failure. The afterload of the is low, because we need to ensure a better forward flow. The heart rate will keep it at a range of 70 to 90. That is the higher side of the normal range, because we need to maintain the cardiac output. Since the patient has cardiac failure, so we can't expect a lot in terms of the stroke volume. So we are kind of dependent on the heart rate for that. Because so we have to be cautious and watch out for atrial fibrillation. And we need to ensure that the contract is always augmented. We should be prepared, and if required, prophylactically we can start inotropes.
Good. So, our motto is there should be no tachycardia, no excessive bradycardia, no increase all these things should be kept in mind. So
Yes.
now my next question is, anesthesia in this patient?
So, ma'am, for this patient, general anesthesia with endotracheal tube in situ, positive pressure ventilation, and we have to keep in mind all the concerns that we have talked about throughout, ma'am.
Okay. What will be induction agent?
Uh, it is important in terms of general anesthesia in this case that during induction, it is an important time when we may have a decrease in contractility. So, my induction of choice, ma'am, here we will go for a slow titrated induction, the opioid-based induction, where we will focus on the benzodiazepines and a dose of fentanyl, 3 to 5 mics per kg, ma'am. Along with that, we can go for cardiostable agents like etomidate in case of severe left ventricular dysfunction. We during induction, we have, and throughout the duty, ma'am, we have the SVR as well, ma'am.
Will you use glycopyrrolate as medication in this patient?
Ma'am,
Glycopyrrolate, ma'am, can be used, ma'am, as glycopyrrolate does prevent excessive vagal tone, can reduce secretion, and ma'am, during reversal, it can be used to get effects of neostigmine if that's what to be used. Some amount of it, some maintain the heart rate and the cardiac output in such patients.
So you have to be very cautious before using glycopyrrolate.
Yes, ma'am.
So
Ma'am, now we'll go for a more titrated approach rather than just a bolus.
if it is, then we can avoid glycopyrrolate.
Yes,
Okay.
ma'am.
And is there any role of in this patient?
ma'am, our patient who is a known case of LBBB on beta blockers, we would avoid dexmedetomidine. Ma'am, in general, a patient with dilated cardiomyopathy, if not on beta blockers or it does not have these abnormalities, it provides respiratory depression. A good drug, ma'am, which will help us sympathetic surge during intubation, laryngoscopy, and even pneumoperitoneum. And most importantly, it has the analgesic sparing effect, where it will reduce the requirement of opioid, and we will have a smooth intraoperative course. Apart from this, even in the post-operative period, it helps in reducing the PONV and helps us to avoid emergence, and we'll have a smooth.
So
So it is important.
It will prevent the sympathetic surge before intubation.
Yes, ma'am. Yes, ma'am.
But this drug will cause bradycardia. Will it be used?
Yes.
So, ma'am, we have the choice of using dexmedetomidine with glycopyrrolate. Ma'am, if both of these drugs are used in a low dose and in a titrated manner, so they'll have a balanced outcome, ma'am, where small titrated doses of glycopyrrolate with a low dose infusion of dexmedetomidine at 0.2 to 0.4 mics per kg per hour, we will have the positive effects of dexmed, and with the glycopy, ma'am, we will have the
Decreased vagal tone.
the
Decreased vagal tone.
decreased vagal tone and
A better heart rate.
a better heart rate, ma'am.
So you are not giving the bolus dose of dexmedetomidine.
Bolus dose should be avoided in these
We'll
cases.
start a low dose maintenance, ma'am.
Okay. Can you give for analgesia?
Yes, ma'am. We can go for thoracic case, ma'am. It will again reduce the sympathetic stress, stability. It is an excellent mode of analgesia both intra and post-operatively. Better respiratory mechanics, ma'am, because the good analgesia will allow deep breathing and coughing as well, and control and opioids largely, so we can facilitate mobilization in the long run beneficial for the patient, ma'am.
What is the disadvantage of giving in this patient?
With thoracic epidural, again, ma'am, still have the chances SVR if not well titrated. And again, ma'am, it's an invasive procedure where we have the epidural space, so it might lead to infections. Time-consuming procedure. So we can supplement the epidural with other regional blocks, ma'am.
What are the target zone? From what are the level?
So ma'am, we can target the thoracic epidural at the level of T8, T9 or T9, T10. And we would want an analgesic from the level of T6 to
Please.
T10, ma'am. So approximately we can expect that the catheter will be 3 to 4 centimeter inside, ma'am.
If given at T8.
If given at T8, ma'am.
Okay. So the fluid therapy is very much this patient. So how will you manage the what is the goal of your fluid therapy in this patient?
Ma'am, so it's a fine balance. We need to maintain an adequate preload, but also avoid overload, as these patients can go into a decompensated heart failure. We need to maintain a cardiac output, and we need heart rate. In state that patients DCM are fluid sensitive, not fluid tolerant. So, ma'am, our goals here will be to go for a goal-directed fluid therapy.
How
So
will
we
you
will
do
be,
this?
ma'am, we go for a therapy with transesophageal echo to see our LV systolic function, our preload status, and ma'am, if available, we should always go for a variation or a pulse variation if the patient is fluid responsive or not. Ma'am, other than that, we see if the urine output is acceptable, and if available, we can also see the lactate levels to see any signs of dehydration or hypoperfusion.
Now I can request Shoykadda, please take over the session.
Okay, thank you. So we come to the last part of the session regarding intraoperative period. So there is a question come about the dexmedetomidine, glycopyrrolate, and other things. And fluid therapy. What do you mean by the goal? What are the goal of the fluid management in this way?
So here we need to see that the patient doesn't go into an acute decompensated failure. So we need to see that we are giving adequate preload for the cardiac output to be maintained, but not and prevent dehydration or volume overload, as both of these are detrimental to the patient.
So, sir, in non-invasive monitoring, when we see that the BP is, without an invasive monitoring or goal-directed therapy, we don't know or the fluid. When we are doing a goal-directed therapy, sir, we have to look that whether or the contractility. In case of a problem with the contractility, then we'll
For
the inotrope for the, and in case we see that the patient is fluid deficient
then
and tolerant, then we'll go with this. Here is, sir, that we will not overhydrate the patient.
So the patient should not be hydrated or unhydrated, and
yes, sir.
actions of the drugs, what are the inotropes we given, how they act, okay, and also that the most important is the tissue perfusion and the oxygenation,
Yes.
whether maintained by the fluid therapy. This is the main for our goal-directed fluid therapy. Okay. So which pressure we commonly see in case of goal-directed fluid therapy?
The pulse pressure.
Pulse pressure variation, and the limit is.
Yes.
So if the pulse pressure is less than 10%, around 10% patient is not dehydrated, but if the pulse pressure variation is more than 13%, the patient will be fluid responsive.
To 30. Oh, okay.
Yes,
in case of T, what we see with T about the fluidness?
But with T,
we can see
the left ventricular. We can have an idea about the right ventricle, whether it is collapsed, and even in we even get a view of the IBC. Overall idea of the and the fluid status, so that we can make an informed decision that whether we should go ahead with inotropes or vasopressors, or we should go ahead with fluids.
Okay. So many times we discuss about the inotropes and the vasopressor kept ready which are the most suitable inotrope on the vasopressor for this patient?
Sir, in these patients, sir, Dobby would be of choice because, sir,
As a
these
inotrope.
cause beta as an anaerobic. It will increase the contractility, which is the main pathophysiology in such patients. And sir, inotrope is usually expect a fall in SV and fluid responses. So in such cases, we can go for noradrenaline.
Okay. We prefer the dobutamine milrinone because dobutamine also cause the vasodilation. Not only
Yes, sir.
inotropic action is increased,
They
that
have
is decrease
vasodilatory
in the
effect.
SBR. This is beneficial for and milrinone inotropic action, no increase in the oxygen consumption. Vasopressor, commonly we use the noradrenaline or
Yes, sir.
only
Yes.
maintain the tissue perfusion. Okay,
Perfusion.
Yes,
this
sir.
is
When
the
it,
main
sir,
motto, but this is not the definitive treatment. Okay, we
Yes.
commonly the epinephrine and phenylephrine, not in bolus dose, phenylephrine infusion. Okay, this is for it. But we have to state that they cause the increase in the SBR. That is also detrimental patient. Oh, now we come to the extubation. How you extubate the patient? In deep plane or light plane?
So, sir, the patient we did not find any airway difficulties. So, given her cardiac
Okay.
status, we will go for a deep plane extubation. We will want to prevent
Deep
all
plane
forms of surge. So, apart from going for a deep plane extubation, we will also have lignocaine, esmolol in hand. That in case if you're suspecting a surge, then we will have the drugs ready to prevent any extubation surge.
Okay. For deep plane extubation, have you kept anything in your hand
Yes,
for
sir.
airway protection?
Yes.
Here we have two things in hand, sir. Since diaphragma's ventilation will be easy, so we can keep the good oropharyngeal airway or the nasopharyngeal airway, and we can also keep a second generation LMA, and we can extubate this patient by Bailey's maneuver.
Very good, very good. Newer guidelines says that when we plan for deep extubation, we have to keep the second cover for protection. Okay, so the smooth extubation is very important for us. Okay.
Yes,
Now, what about the dexmedetomidine? Dexmedetomidine start in only the maintenance. This is 20 minutes before the induction. What is the advantage of that? That we the decrease in the dose of the induction, whatever be intermediate or so we avoid the sudden hypotension. And the dexmedetomidine is blood. If this occur within the 20 minutes of the before induction, then only if there is bradycardia occur, then copyrolate as a anti-secretory drug. Okay, so
Yes, sir.
for the anti-secretion drug here, so to control the secretion, if we give this in the background of the dexmedetomidine, this might not cause cardia. Now come to the post-op. Post-op, where you send the patient to the ward or ICU?
One question.
Yes, ma'am.
Okay, okay.
Will you use Sugamadex during extubation? Because it's a cardiac case, we generally use Vecuronium. So, Dex.
So, ma'am, the choice of and we have used Vecuronium or Locuronium. So, ma'am, we Sugamadex, but ma'am, again, we are planning for it. We will ensure adequate reversal from the muscle relaxation, but sedation will continue, ma'am. And then we will gradually bring the patient back from the sedation.
Okay. There are some rare cases where they have faced bradycardia, even cardiac arrest, due to we have to be
Sugamadex.
very
Very
careful,
cautious.
Very cautious.
very cautious.
Yes, ma'am.
So we can continue the lower dose 0.2 micrometers during the extubation. Okay, that will cause the only the patient, but that
Okay.
will decrease the airway reflex and the stress response of the extubation. Okay, to patient to isolate.
Sir, this patient will definitely require monitoring. So depending
Hmm.
on the induction, intra-op, and the post-op and the patient's an HDU where she will be monitored. If the patient, if based on the intraoperative findings, the patient might require monitoring as well.
Okay, so what are the special monitoring for in ICU?
Approximately.
In this is
And
maybe
since we already have an
Yes.
art line in C2, then we will go for. And if my ICU is well equipped with a flow track, then throughout the night, ma'am, then throughout the night, sir, we can go for a cardiac output and the SVV and the PPV monitoring. And if
focus.
these are not available, monitors are not available, then we can go for real evaluation, the fluid status and the other status of the patient, sir.
Okay. IBP line, we do not remove the IBP line in OT. We send the IBP line for the flow track monitoring for minimum 24 hours for after OT. Okay. Transesophageal echo, if there is any symptom or in doubt or there is increase in the dyspnea, decrease in the oxygen saturation, at that time we quickly go for the focal examination. Okay. Analgesia, how you plan?
Sir, we will go for a multimodal analgesic. So, sir, paracetamol first line. NSAIDs better avoided in patients. So we can go for opioid titrated and low doses. There are certain regional anesthesia techniques that these include the port side location, certain plain blocks such as costal tap, erector spiny block, paravertebral block, and shown great uh, such in these cases. And so obviously we can always go for an epidural analgesia.
We try to give the maximum pain decrease by
Yes,
multimodal analgesia. Okay, we
yes,
give the
sir.
less opioid to prevent the hyperthermia, but of analgesia like regional blocks. Initiatives there may be some causes because there is a chance of renal compromise of this patient. Can you say why there is chance of renal compromise for this patient?
So, sir, the
She is only
NSAIDs, sir, cyclooxygenase inhibitors. So, particularly, sir, we will find the of COX1, COX2 inhibition, we'll find that there is a decrease in the GFR. So based on the decrease in the GFR, it will act as antidiuretic hormones. They will have similar function like antidiuretic hormones and there will be fluid retention. Want in this patient. So NSAIDs, it is always better to avoid in heart failures.
in NSAID, it is better to have it is better because the cardiomyopathy, there is decrease in the cardiac output, so there is decrease in the renal flow also. And
Yes,
anything
sir.
concern increase in the abdominal pressure may cause decrease in perfusion.
Because in renal perfusion and these, yes.
Very common laparoscopy. Perfusion is long standing. The increase in the renal. Okay.
Yes.
Okay.
Yes,
So
sir.
one thing we miss intraoperatively, use any inhalation anesthetic.
So we can use inhalational anesthetics, but it's always better to at a lower MAC depressants, and it might, if used in at a higher MAC, they might be detrimental. So we can use them, but preferably at a MAC less than 1.
Less than 1. So only we use the inhalation anesthetic to prevent the awareness. As we maintain, the depth of the anesthesia will be maintained with try to maintain with the IV drugs also. Okay, whether
Yes,
you
sir.
use nitrous or
Nitrous can again has a vasodilatory as well as a myocardial depressant effect. So, sir, it's better to avoid and go with air.
what is the relation of the nitrous with laparoscopic operation?
Sir, as a
Nitrous
insufficient
always,
agent. Sir, combustible.
yes.
It's supposed combustion.
Not only that, nitrous. What is the effect of the nitrous? Nitrous will expand the air.
So
The
vasodilatory.
carbon dioxide also comes to the thorax, to the diaphragmatic spillage. The nitrous can decrease, increase the volume of the nitrous oxide within the chest, and increase the intrathoracic pressure. Okay.
Yes, sir.
And second
Yes, sir.
point, if there is any gas embolism, there is a chance of increase in the size of the gas embolism also. In case
Yes, sir.
of if we use. And another point, these patients may have the associated with pulmonary hypertension, and
Yes, sir.
nitrous always increase the pulmonary
Pulmonary
hypertension. of the
hypertension.
Okay, so we try to avoid the nitrous. We will maintain oxygen with
Air.
oxygen with
Yes, sir.
air.
Air,
And
sir.
ideally-
Medical air, sir.
Medical air.
Nowadays, there is come a xenon gas is an inert gas. This is very costly. We do not use that.
Yes, sir.
Okay. Acha, what is the ventilator? Is pressure control ventilation or volume control ventilation?
So there is,
Which one you prefer?
so there is not much difference, but we have to make sure that the airway pressures are not too high. The positive end expiratory pressure, the PEEP is not too high, because we have to make sure that while giving positive pressure ventilation, we have to make sure that the positive intrathoracic pressure is not so high that the cardiac output falls down. So we can opt for a pressure controlled or a volume controlled ventilation, but we have to keep on monitoring the EGCO2, the PEEP, and with the invasive monitoring, we have to keep an eye on the cardiac output.
Yes. So there is basically no difference between pressure control and volume control. But if there is increase in the intrathoracic pressure, in case of pressure control ventilation, we can see the rise of the pressure due to false positive, due to the insufflated gas within the
Gas, yes, sir. Yes, sir.
In that case, there is a chance of hypoventilation of this patient. So we
Yes, sir.
commonly ventilate.
Volume control.
Okay.
Control, sir.
That will maintain the volume and also the FRC also. Okay. Last point, whether the patient has more chance the PONV. Whether
Yes, sir. This patient is definitely at a high risk for PONV.
PONV, and if the PONV, or you prevent that, and what are the preventive measures? What is that?
Is definitely at high risk for PONV, because we have used inhalational agents. We have used opioids in high doses. So these are points which are in of the patient having PONV. So we have to ensure that the hemodynamic stability is maintained throughout. We have to avoid hypoxia.
Not insufflated gas, always the peritoneum. Insufflated gas
Yes, sir.
within the peritoneum. So of peritoneum stimulation, that will cause a nausea. Okay. And say,
Yes, sir.
what
Yes,
are
sir.
the
So we will
preventive
go for
measures?
So we will go for pharmacological prophylaxis, sir. We will go with ondansetron. Since the patient is diabetic, we might avoid dexamethasone. But again, for rescue therapy, if the patient has episodes of vomiting, we might go with dexamethasone, and we might even consider clopramide. So the post-operative management will be to make the patient kept head up, give adequate oxygen, maintain hemodynamics, and make sure that the PONV does not set in, sir.
Okay. Now, I think this is, we try to cover all the aspects.
One question.
Now it is
Shekhar, the one question.
open for. Bolo.
Volume
Say the
control
question.
ventilation is preferred. Volume control ventilation is preferred for this patient. So what will be your ideal tidal volume?
Ma'am, 4 to 6 ml per kg, ma'am.
4 to 6 or little bit more, 6 to 8. Low tidal volume, definitely.
Yes, ma'am. Ma'am, with 4 to 6, if we are being able to adequately wash out the CO2,
Okay.
then we'll maintain with 4 to 6. But if you're not being able to wash out, then we can increase up to 8 ml per kg.
Yes, yes.
So if there is no lung pathology, patient is not for restrictive lung disease or any case of any lung, yeah, we slightly go to the higher normal value. Okay, 8 ml per kg.
Yes.
For that, it will go up for the diaphragm, prevent the decrease in the FRC. Okay. I
Yes,
think we try to complete all the things. Now the discussion is open for the whole forum and the house. Subhajit and Harsho and other people.
Yes,
And the other seniors
first,
and my colleagues. Also, you can add
Especially the
what you
students.
miss and other things.
yes,
That was
Especially
truly
the
insightful and clean. I'm
I
sure
really
our
thank-
PGTs found that immensely valuable. Really.
I really thank Shoykot and Rajashree. It was excellent. I think you have covered each and every corner of the topic. And congratulations to Indradeep and Shilpa.
Shilpa.
It was brilliant. Yeah, it
Thank
was
you, sir.
brilliant.
Thank
So,
you, sir.
PGTs, those who have joined, if you have any queries, don't miss this opportunity. You ask your question. You can raise your hand and ask your question.
Within this period, I throw a question. This is not a question. This is just a discussion. Nowadays, there is a many controversy with segmental spinal anesthesia in case of lab cholecystectomy. So, in this patient, any experience for segmental spinal, and if there is controversy or any other knowledge, you can write.
Anyone is having experience
Yeah.
segmental in this patient, share your experience.
আমার মনে হয় ততক্ষণ আমরা এগুলো করতে থাকি, কোশ্চেন্স করতে থাকি। হ্যাঁ, তাহলে ইট ইজ অলরেডি
পোস্টগ্রাজুয়েট স্টুডেন্ট হলো।
হ্যাঁ, প্রথম 58-year-old is undergoing an emergency laparoscopy. Following base describe the optimum hemodynamic strategy to maintain the systemic perfusion. Maintain a high on normal heart rate to relatively fixed stroke volume, aggressive fluid resuscitation to maximize the Frank-Starling law, system resistance to ensure the coronary perfusion, a smaller titration to achieve the heart rate between 50 to 60. স্টুডেন্টরা কি কেউ অ্যানসার করবে? Anyone can go except our student. অন্য কলেজের পিজিটিরা, everyone is
Please attempt.
to answer. এখানে কোনো ভয়ের কিছু নেই বা ভুল নেই।
তোমরা জিজ্ঞাসা করো না,
Exactly.
তোমরা জিজ্ঞাসা করো, তোমরা চেষ্টা করো।
This is just preparatory phase. So,
Exactly.
আমার মনে হয় আমরা এগিয়ে চলি।
সেইটা আমার মনে হয় না, আমাদের মনে হয়
আচ্ছা,
মানে প্রসিড ডিসকাস করব।
আচ্ছা, প্রথমে বলি, বলে দিই aggressive to maximize the Frank-Starling mechanism. আচ্ছা, aggressive dilated cardiomyopathy. আচ্ছা, অ্যাকর্ডিং টু Frank-Starling law ততক্ষণই কাজ করছে যতক্ষণ clear myocardial is present. After that, when the limit of the stretching is over, the Frank's turning law is not act. So there is no increase in the inotropic action of the heart. So there is a chance of fluid retention and the fluid congestion. So more chance of congestive heart failure. So discard the B options. Three option: increase systemic vascular resistance. Increase systemic vascular resistance definitely increase coronary perfusion, but at the same time the forward flow is hampered. So we vascular resistance. A smaller heart rate 50 to 60. The lower heart rate is beneficial for the definitely, but not for the forward flow, as the volume we stress on the heart rate to maintain the cardiac maintain in high normal state. Okay, so for BC we go for the first option, maintain normal heart rate to compensate relatively fixed stroke volume. Okay, come to the second option. And during a major abdominal procedure, a DCM patient mean arterial pressure drops 75 to 50, global hypokinetic, significant regurgitation, but the inferior vena cava appears distant. Most appropriate for administration of crystalloid bolus, initiation of the dobutamine infusion, phenylephrine bolus, and the titration to high dose of the volatile anesthetic technique. I think a question uttor অনেকেরই জানা আছে যাকে we go to the discussion.
এটা তো বলতেই পারে, এটা ভীষণ স্ট্রেট ফরওয়ার্ড কোশ্চেন।
Everybody will know the answer.
এটা সবাই পারবে।
ইন্দ্রদীপ অ্যান্সার দেখিয়ে দাও। Administration of same thing as the ear vena cava, so there it is signified that there is deficit, but the arterial pressure is increased, decreased. If we administer the phenylephrine bolus, abrupt rise of the SVR, this will further decrease the forward flow, and also this cause the bradycardia. So we also exclude the phenylephrine. Last thing, titration to high dose of the volatile anesthetic technique. Volatile anesthetic is always cardiac depressant. So we never use the volatile anesthetic in this operation in high dose. There is, as per discussion, this is always in low dose. Which of the following parameters obtained via pulse counter analysis is the most reliable indicator that a DCM patient will increase their cardiac output in response to fluid bolus? CBP 15 millimeter Hg, pulse variation greater than the 13 in clinical ventilated patient, a high systemic vascular resistance index, and the mean arterial pressure below 60. This question is also discussed in our discussion. I think everybody has an idea. Indradeep, see the question answer. As Indradeep previously said, that pulse pressure is the best indicator of fluid balance. CBP only don't arterial pressure, not the whole. This is there is nowadays it is shown that there are various loopholes around the resistance index. We get only a rough idea. SVR is below 14, that means fluid deficit, but the correction of the fluid deficit is cannot be reflected by SVR. Arterial pressure below 60, this is also a vague idea because we mean decrease depend various other especially pressure may be high in spite of the fluid deficit. Pulse pressure variation mechanical is choice of the answer, but the the pulse pressure variation can only use in case of a paralyzed patient, not in case of spontaneously respirating patient. After the operation in spontaneous respiration, not the indicative of the okay. Last question: during the cholecystectomy, the ETCA rise to 50 meter Hg despite increasing the minute ventricular arrhythmia. What is the most critical next step now? Administration of the bolus immediately require the surgeon to deflate the peritoneum and check for the carbon dioxide. Cutaneous emphysema, increase the PEEP to 15 centimeters, improve the oxygen to sevoflurane to isoflurane. I think experience everyone know that answer. Go to the answer. Okay, so always the pneumoperitoneum is primary concern of. If the carbon dioxide goes to the subcutaneous plane, then absorption of the carbon dioxide, and this carbon dioxide is very much difficult to manage only by increasing the respiration. Amyotrophic case of a heart failure patient or in dilated cardiomyopathy patient, though amiodarone is a good and prescribed, it has all inotropic action and all chance of refractory. So, in case of hypertension, we generally add the amiodarone. Increase the there is already there is increase level to 55 millimeter Hg. So if we increase PEEP 15 millimeter Hg, that is the highest level of the PEEP, oxygenation may, but there is a chance of more hypercarbia. So this option also excluded, and switching over to sevoflurane, I think these do not give the much benefit to us. Okay. I think all the question is completed. 2017. So this is a very important topic for academic purpose. Both the MD in all.
Yes.
I think
So,
uh,
anybody has
okay.
any question, you can still
Any
ask.
question or that we missed?
Any comments, any
or
suggestion?
Any comment, any suggestion?
I think participant
Raise their hand.
there are 91 participants. Now there is 50. Really happy that
Can you
20
repeat?
participants join with us.
100 participants.
So for this day, this is a very good thing for ISA.
Absolutely.
This is very good thing.
All thanks to you. But it was an excellent discussion. I think it was a very vivid and excellent discussion, and everybody thought.
Want to speak something?
Yeah. So
Yeah.
Good evening. faculties and my dear PGTs. So one common Shoikot on should be a first choice. I have availabilities of other safer analog in this case.
About the PON, what you say?
If the DCM, the optimal we have a
Yes, the main conversation that we always remain cautious about the prolongation. Uh, I think electron causes the mainly the arrhythmic action. If we give the ondansetron is very quickly and very rapid dose. Okay, if we give the ondansetron IV and it will go along the fluid as per requirement of the patient, it causes not much problem in our day-to-day. But if we and with other drugs, the PONV is controlled, then there is no need of take any risks of ondansetron. This is also long. You can give the one day dose also.
another
But if we give ondansetron in fluid or non-rapid IV, so there is probably no
that's why I'm telling if I
formation
have
or
choice
arrhythmia.
in my tray
the
if other drugs,
rate-
then I can use
Rate of
otherwise.
very important. The ingestion is very important.
And second, the concern regarding the right as per Enigma 2 trial, so it's not concern of preventing cardiac use of site use may not be a great hint.
Yes, there is advantage of the nitrous oxide. If we use the nitrous oxide, we can use the inhalation anesthetic in lower neck. Okay.
Exactly.
Only if the patient has established pulmonary hypertension. Okay. Otherwise,
Say the disease condition is not a struggle to use this.
It's not
And another issue is Shoikot, with due respect, use of sign contraindication of dexmedetomidine remains the major kind of systolic condition. So may drawback or cautious.
has
Contraindicated theoretically.
established LBB, we do not go for the dexmedetomidine directly. But the advantage of the dexmedetomidine is excellent energy coordination. Okay. So that
In
we can
this case, I'm
also
telling. Otherwise, dexmedetomidine is our great choice. In all
Yes,
the
I
cases.
can say something. Devananda, আমরা বলি হ্যাঁ বলছি জলই জীবন বাংলায় but for a heart failure patient it's not life like that. In a combination sometimes or happens about something like that, but overall this is everybody, and it's a great discussion. What do you think today, as it is first one?
Yeah.
It was
Really useful.
Something I want to add something. The in dexmedetomidine, if there is established LBBB, we will not go for dexmedetomidine. Established LBBB itself is There is no question. But if the patient is not having LBBB, then that we can but we have to be very cautious about the dose. Use the bolus. Only
Bolus,
maintenance dose along with pyrolate we can use to sympathetic surge before intubation. That can be given. Many papers, many studies.
Along with this
So
context, the use of anti-logo
maybe a poison, I think, or maybe a poison. Okay.
we prefer
And before one thing I have to say, not only these 4%, all the faculties of our department and all students help us to prepare this presentation and to them. So,
Thank
if I
you.
want to say actually,
Thank you so
it
much.
is a great team, Ajikor,
Excellent
Yes.
work.
and
excellent.
I
It's really
our scientific secretary and our co-scientific secretary, Dr. Shubhajit Go and Dr. Harshaprabhu Datta. So it's a quite time. So can we?
Yeah, just
Permission of
before
all.
conclusion, I want to announce, I should say news. In the next month also, we are having one offline and one online CME. So our offline at Q City Medical College, 15th of March, one of and so it will be an excursion also. And we'll be meeting online of March. The topic will be the anesthetic management of a patient with hernia gravis for thoracoscopic thymectomy. So it's another good topic. So all of you, please. For the I want to tell you that we will be having our boot camp on 23rd and 24th of May. 23rd and 24th of May. So before your exam, please attend, register and do attend. And we have our zonal conference on 2nd, 3rd and 4th of this year. This year we'll be having our zonal conference. So on 2nd of 3rd and 4th October, it will be conference. So all of you, thank you so much. It was a great discussion, great academic phase for today. So Sanjay Da, any one of you can please conclude the session.
So that is the conclusion. That is the conclusion, Shubhajit. Okay, done.
Okay,
And also,
okay, done.
Thank you.
Okay, bye. Okay,
Thank
bye.
you.
Okay, thank you. Thank you, everyone.
thank you.
Okay, good.
Sir.
Thank you.